This is Dr. Stephen Harris. Now we'll be covering Section 2, which is Autonomic Pharmacology. Chapter 1 is going to look at the autonomic nervous system. When you think about the autonomic nervous system, you have to consider the anatomy of the autonomic nervous system, and we will look at that in a diagram on the next page. You also want to consider the location of the ganglia. We will also cover that in the figure on page 40. This diagram is very important for you to understand what's going on with the autonomic nervous system. First, we're going to start by reviewing a couple of things that you should already be familiar with. You should be familiar with the origin from the spinal cord for both parasympathetic and sympathetic pathways. We know that the parasympathetic nervous system arises from the craniosacral parts of the spinal cord, whereas sympathetics arise from the thoracolumbar regions of the spinal cord. Again, things that you should already know from anatomy. Also, you should remember the location of the ganglia for these pathways. For example, if I said, where are the parasympathetic ganglia located? You should remember that those ganglia are located at or near the organ being innervated. And what that means is anatomically, you're going to have a long preganglionic fiber and a short postganglionic fiber. But of course, the sympathetic ganglia are going to be found right next to the spinal cord, what we call paravertebral ganglion. And what that means is you're going to have a short preganglionic neuron and a much longer postganglionic fiber. So think about origin from the spinal cord and location of the ganglia to bring your anatomy back into this diagram. When you look at the different parts of the picture here, we have parasympathetic pathways, we have 3 different types of sympathetic pathways, and down at the bottom of the figure, we've got a somatic motor neuron, so we can talk about that pathway as well. So as a whole, we're really looking at the components of the peripheral nervous system. Let's come up with 2 very basic rules to remember some important parts of these pathways. The first thing that I would have you notice is that every one of these pathways begins with the release of acetylcholine. So let's say it this way. Acetylcholine is the first neurotransmitter, whether it's parasympathetic, sympathetic, or somatic. Each of those pathways starts with releasing acetylcholine. Rule number 2. The first receptor that's acted on in each of these pathways is nicotinic. Notice that all of the ganglia have nicotinic receptors, the adrenal medulla has nicotinic receptors, and skeletal muscle has nicotinic receptors. So to summarize, each pathway starts with acetylcholine binding to a nicotinic receptor. Then we compare that there are 2 different types of nicotinic receptors. There's N sub N and N sub M. Let's start with the N sub M receptors, which are found on skeletal muscle, because that's the only location where you're going to find this receptor. In fact, the easy way to remember N sub M is that can stand for neuromuscular. That's the receptor found at the neuromuscular junction. All of the other nicotinic receptors in the body are going to be N sub N. You might remember the sub N for nerves. When you find a nicotinic receptor on nervous tissues such as the ganglia, that's going to be N sub N. But what about the adrenal medulla? Is the adrenal medulla nervous tissue? If you remember from embryology, of course it is. Derived from neural crest cells, the adrenal medulla is nervous tissue, so it's got the ganglionic type of receptor, which is N sub N. If I also reminded you that you have nicotinic receptors in the CNS, what type of nicotinic receptors would those be? That's right, those would also be N sub N receptors. When we take a look at the rest of the parasympathetic pathway, you've got a postganglionic neuron that's also releasing acetylcholine. In fact, let's look at the term cholinergic. When I think about cholinergic nerves, obviously those are nerves that are releasing acetylcholine. Isn't it true that every one of the parts of this diagram, each part of this diagram has at least one cholinergic nerve? We've already said that each pathway starts with the release of acetylcholine. Parasympathetic pathways have 2 cholinergic nerves. What if I asked, what are the cholinergic receptors? We've already seen that acetylcholine can bind to nicotinic receptors, so N sub N and N sub M are different types of cholinergic receptors. But when postganglionic neurons of the parasympathetic nervous system release acetylcholine, they bind to muscarinic receptors. Muscarinic receptors are the terminal receptor in parasympathetic pathways. So each of the organs innervated by parasympathetic pathways contain muscarinic receptors. Collectively, your cholinergic receptors are all nicotinics and all muscarinic receptors. When I look at the sympathetic pathway, notice that the postganglionic nerve this time is going to release norepinephrine. We would call that an adrenergic nerve. Adrenergic nerves release norepinephrine, and then of course norepi is going to bind to various alpha or beta receptors found on different organs in the body. So norepinephrine is an adrenergic neurotransmitter binding to adrenergic receptors, which of course are alphas or betas. Now let's look at two very special parts of this pathway. The first one is the pathway that innervates sweat glands. Sweat glands are very important because they're different from the rest of this pathway. Notice a couple of things that make this a special pathway. First, sweat glands are innervated by sympathetic nerves. It's a sympathetic innervation for the sweat glands. Well, what's different? The postganglionic nerve releases acetylcholine. It's a sympathetic pathway with two cholinergic nerves. That's different. In fact, it makes it look more parasympathetic-like because of the two cholinergic nerves. Notice the terminal receptor. The receptor that's actually found on the sweat glands, muscarinic, also kind of reminds you of parasympathetic pathways. What makes it sympathetic after all? Origin from the spinal cord. It's not really the transmitter itself. It's the anatomy of the system that makes it sympathetic. So it's the one special case of a sympathetic pathway that ends in a muscarinic receptor. Now, these sweat glands are what we call thermoregulatory sweat glands. They're sweat glands that regulate the body's temperature. In fact, there are most sweat glands in the body that help to control your temperature. Remember, these are different. These are special. Many times, they're an important part of a test question. You would also argue that the adrenal medulla is a special pathway. The adrenal medulla does not have a postganglionic nerve as part of its pathway. It's got a preganglionic nerve releasing acetylcholine, binding to N sub N receptors, but there's no activation of a postganglionic nerve. So, when you summarize what the adrenal medulla does, it really acts both as a ganglia and as a postganglionic neuron. Remember, the function of a postganglionic nerve is to release a transmitter. The adrenal medulla can do that all by itself. It's going to produce and release mostly epinephrine with small amounts of norepinephrine as well. Epi is released into the circulation. We call this type of transmission neurohumoral. If you break that word down, neuro, nerve, humoral, blood. It's nerve-to-blood transmission, the adrenal medulla releasing transmitters into the blood. So when epinephrine is in the circulation, it's going to be able to bind to any alpha or beta receptor that it can bind to. It can find in the circulation. It will bind to those receptors. So once again, sweat glands, the adrenal medulla are special parts of this pathway. Down at the bottom, you see the somatic motor nerve. Single neuron releasing acetylcholine binding to N sub M receptors. I think this is such a critical diagram for you to understand autonomic pharmacology. In fact, it's a mistake for you to start memorizing a bunch of drug names until you have a solid foundation from this diagram. Let me show you how to use this picture effectively to discuss and describe properties of different drugs. So first, let's talk about muscarinic agonists. The thing that I would want you to do is, can you place the muscarinic agonist on this diagram? Sure, find muscarinic receptors. That's where this type of drug is going to stimulate. In the top right of this picture, you see various organs that contain muscarinic receptors. The exercise that I would like for you to do right now is to consider 5 organs. Those organs would be the eyes, the heart, the lungs, the GI tract, and the urinary tract. So you're basically starting at the top and working your way down. And answer these questions. What does a muscarinic agonist do to each of those organs? Start with the eyes. A muscarinic agonist is going to mimic the parasympathetic nervous system, so what happens to pupil diameter? It's going to constrict. You get meiosis from a muscarinic agonist. What about the heart rate? Parasympathetics slow the heart down, so a muscarinic agonist gives you bradycardia. What's a muscarinic agonist going to do to the lungs? Is it going to bronchoconstrict or bronchodilate? Which of those is consistent with parasympathetic action? Of course, that's bronchoconstriction. Can you pause right there? Can you identify why a muscarinic agonist would be harmful to a patient with asthma? Sure, because of its ability to bronchoconstrict. What about GI motility? Parasympathetics increase motility. Muscarinic agonists will increase GI motility. And urinary motility will also be increased. Once again, those are all things that are consistent with parasympathetic activation. But where else on my diagram would a muscarinic agonist act? It's obviously very parasympathetic-like, but you remember the sweat glands also contain muscarinic receptors. So a muscarinic agonist will stimulate sweating. There's the one sympathetic action of a muscarinic agonist, that is on the sweat glands to cause sweating. Of course, if you can do that exercise for a muscarinic agonist, you can do the same thing for a muscarinic antagonist. Place that drug up in the top right corner of this picture. It blocks muscarinic receptors found on various organs. Let's go through the same 5 organs again. Start with the eyes. What does a muscarinic antagonist do to the pupils? Obviously, if you block the parasympathetic effect, the pupils will dilate. You get mydriasis with a muscarinic antagonist. What happens to the heart rate? Muscarinic blockers, blocking the parasympathetic effect, you get tachycardia. Muscarinic antagonists cause the lungs to bronchodilate. Muscarinic antagonists would cause both a decrease in GI and urinary motility, the opposite of what we saw for the muscarinic agonist. But of course, don't forget, there's one other place to place a muscarinic antagonist on this picture. That would be at the sweat glands. Muscarinic blockers will block sweating. Now think about what you know about that type of drug. If I block sweating, my temperature is going to go up. If my temperature goes up, what do you think your blood vessels are going to do in an attempt to try to lower the temperature of the body? That's right, your blood vessels are going to dilate. So what's a characteristic of an overdose on a muscarinic blocker? A flushing reaction. Absolutely right. Due to the vasodilating effect, that's really a compensation to the increase in temperature. Our third and final group that we'll discuss on this picture, acetylcholinesterase inhibitors. If I just simply ask you, where do you find the enzyme acetylcholinesterase? You should come up with a very broad answer here, and that answer would be, well, I find that enzyme in any synapse where I've got acetylcholine. I need a way to break that transmitter down, so acetylcholinesterase is found in multiple locations on this figure. Every synapse that contains acetylcholine, I will find that enzyme. So what does an acetylcholinesterase inhibitor do? Increases the half-life of the neurotransmitter. Acetylcholine lasts longer in the presence of that type of drug, so you can imagine that type of drug is going to have effects, both sympathetic, parasympathetic, and even somatic effects because of more acetylcholine. And those are all ways that you should think about how to use this diagram to study pharmacology, especially as it relates to autonomic nervous system. When we look at the neurotransmitters that we just discussed in the previous diagram, we know acetylcholine acts on nicotinic and muscarinic receptors. Norepinephrine acts on adrenergic receptors. Those would be alphas and betas. Notice that the text reminds us that happens in innervated tissues. Norepinephrine is not really going to work on non-innervated adrenergic receptors. We will discuss that a little bit more on another slide. We also didn't discuss the transmitter dopamine in the previous diagram. Most often when you think about dopamine, of course that's a very important neurotransmitter in the CNS. It does have some actions in the periphery though as well. There are dopamine D1 receptors found on renal blood vessels, so when dopamine acts on these receptors, it causes renal vasodilation. Epinephrine, of course, is synthesized and released from the adrenal medulla. It activates really all alpha and beta receptors, whether or not the tissues are innervated. Now, this should make sense because we know epinephrine is released into the circulation. so it can find receptors even if they're not innervated by nerves. It's a key difference between epi and norepi. We want to look at blood pressure control mechanisms because one of the major roles of the autonomic nervous system is to maintain normal blood pressure. Of course, we remember that blood pressure is a function of TPR times cardiac output. If you boil that down, basically what we're saying is blood pressure is a function of what your blood vessels are doing and what your heart is doing. We're not really discounting the influence of the kidney here. Of course, kidney has a major role in regulating fluid volume. But if the choice ever comes down to blood vessels or the heart, which one of those two has the greatest influence on your blood pressure, I think you would have to choose the blood vessel. TPR has a greater influence on your blood pressure because even minor changes in vessel diameter has a significant consequence on TPR and therefore blood pressure. So here's a basic rule that you can follow. Any drug that changes TPR, because it's a vasoconstrictor or a vasodilator, it's going to change the blood pressure. And here's where the autonomic nervous system comes in. When I change the blood pressure, the autonomic nervous system is going to try to compensate for that. If you look at the bullet point down here that discusses changes in mean blood pressure, if I get an increase in blood pressure, perhaps because I was on a vasoconstrictor drug, what's the autonomic response going to be? That's right, it's going to be to decrease cardiac output and heart rate. So I'm going to get a parasympathetic response to that high blood pressure that tries to decrease cardiac output. On the other hand, if I have a vasodilator that decreases TPR, that drug will decrease the blood pressure, and that causes an autonomic compensation to increase sympathetic activity to the heart, increasing cardiac output. So in a nutshell, what that means is if I increase the blood pressure, I'm going to decrease cardiac output. The heart will respond in the opposite way as the blood pressure. If I get a drop in blood pressure, I see an increase in cardiac output. And those type of reflex compensations are very important for you to understand for your exam. The effects of changes on blood pressure on the heart are shown very clearly in this diagram. If you start in the upper left-hand corner with an increase in blood pressure, once again, possibly that is because of a vasoconstrictive effect of a drug. With the increase in pressure, I'm going to get a baroreceptor discharge, which signals the cardiovascular centers of the brain that we need an autonomic response. What would that response be if I have high blood pressure? Well, I'm going to fire parasympathetic pathways and at the same time inhibit sympathetic pathways. Pressure is up, I need parasympathetic activity. When parasympathetics fire via the vagus nerve, that will decrease the heart rate. At the same time, decreasing sympathetic activity also contributes to a decrease in the heart rate. If you look at the box on the left, what are the receptors that are controlling the heart rate? Well, it's beta 1 and muscarinic M2. So in this diagram, when I fire parasympathetics to the heart, I will stimulate muscarinic M2 receptors to cause bradycardia. Do you remember? What type of G protein are muscarinic M2 receptors coupled to? That's right, it's GI. They're going to cause a decrease in cyclic AMP, and that leads to a decrease in the heart rate. On the other hand, what about beta 1 receptors? Well, beta 1s are GS. All betas, in fact, are GS. So beta 1s increase cyclic AMP. When they're stimulated, that will increase the heart rate. In this diagram, we're trying to get the blood pressure back to normal because we started with high blood pressure. So we fire parasympathetics, stimulate M2s, we inhibit sympathetic firing, and we stop the firing to the beta 1 receptor. When it comes to your blood vessels, we have alpha 1 and beta 2 receptors that are working very effectively to control vessel diameter. Alpha 1s want to vasoconstrict and beta 2s vasodilate. So notice we don't have a parasympathetic component controlling the blood vessel. It's two different adrenergic receptors. Let's think about their G proteins. Alpha 1, of course, they're coupled to GQ. GQ, that's your phospholipase C, IP3, and calcium pathway. That's going to cause constriction of smooth muscle. Beta 2, all betas are GS. When I increase cyclic AMP in smooth muscle, that leads to vasodilation. We're going to discuss exactly why that happens later on. For right now, I'm going to ask you just to buy into that fact that if I increase cyclic AMP in smooth muscle, it causes smooth muscle to relax. Now contrast that with what happens when I increase cyclic AMP in the heart. If I stimulate beta 1s, I'm going to increase the heart rate. But obviously there's a difference between cardiac muscle and smooth muscle. If I look at the bottom of this diagram, what if I were to give a drug that can increase TPR? Obviously, by looking at this diagram, you might think about an alpha-1 agonist. An alpha-1 agonist would vasoconstrict to increase TPR. That's going to increase blood pressure. Now, can you work your way through the rest of this diagram? What should happen next? If I increase the blood pressure, what do you expect the heart to do? It should respond in the opposite direction. The pressure is up, therefore I get a reflex bradycardia. The receptor that mediates that bradycardia, M2. A classic step 1 question would be to discuss not just the alpha-1 agonist, but perhaps the effect of a pretreatment with another drug on that alpha-1 agonist. For example, what if you pretreated with a muscarinic blocker and then you gave an alpha-1 agonist? How would that change the scenario? The muscarinic blocker would not stop the alpha-1 agonist from binding to alpha-1 receptors. What it would stop is the reflex bradycardia. The alpha-1 agonist would cause the pressure to go up. TPR and blood pressure would increase. But when you go to fire that reflex through the parasympathetic nervous system to the heart, you get no effect because your muscarinic receptors are blocked. What if I gave a vasodilator? For example, a beta 2 agonist. Beta 2 agonist will vasodilate, decrease TPR, decrease blood pressure. When the pressure goes down, you would expect the heart rate to go up by a reflex. So that reflex tachycardia happens when you fire, this time, sympathetic nerves to the heart, stimulating beta 1 receptors. So what type of drug could you use to stop a reflex tachycardia? Since it's mediated by beta 1 receptors, a beta 1 blocker would stop the reflex tachycardia. It's important to think about the types of drugs that can stop reflexes. There's a note in the margin that discusses this. Reflex brady, we've seen, can be blocked with muscarinic blockers. Reflex tachy can be blocked by beta 1 blockers. But what type of drug blocks all reflexes? That would be a special group of drugs we call ganglion blockers. Ganglion blockers block at the N sub N receptor. And remember that all ganglia have those types of nicotinic receptors, whether it's parasympathetic or sympathetic. So blocking at the ganglia by blocking N sub N receptors stops reflex brady and reflex tachy. If I pretreated with a ganglion blocker and then gave an alpha-1 agonist, I would see the blood pressure and TPR go up, but then no effect on the heart because I'm preventing that reflex from happening and causing bradycardia. When we consider blood pressure control mechanisms, there's a thing called a hormonal feedback loop. And this happens when you get a decrease in mean blood pressure, leading to a decrease in renal blood flow. That decreased renal blood flow is going to activate the release of renin and activate the renin-angiotensin-aldosterone system. And this is illustrated very nicely in the following diagram. If you'll notice from this figure, it only works in hypotension, a drop in blood pressure, decreasing renal blood flow, causing renin release, activating the renin-angiotensin-aldosterone system. This system, of course, can increase your blood pressure through the actions of angiotensin II and also the actions of aldosterone. Angiotensin II is a potent vasoconstrictor to increase TPR. Increasing aldosterone going to conserve sodium in water, so you get an increase in blood volume, increasing cardiac output, and that also can increase your blood pressure. The note in the margin reminds us that antihypertensive drugs, of course, they're designed to lower the blood pressure. And when you do that, it's possible that your autonomic nervous system can oppose the action of your antihypertensive drug. For example, if you use a vasodilator to lower someone's blood pressure in the treatment of hypertension, it's possible that compensatory mechanisms such as reflex tachycardia and salt and water retention can occur, and those actions would oppose your antihypertensive. It's the rationale behind adding multiple antihypertensives to offset some of the body's own compensatory mechanisms. When you think about blood pressure and heart rate, we can actually look at both of those in this type of tracing problem. The way that step 1 would utilize this information is they would ask you to identify a certain drug given its characteristics and its effects on blood pressure and heart rate. When we think about blood pressure, if you look in the upper left of this slide, you notice that there's systolic pressure represented by the peak of this graph, and diastolic pressure is the trough of the graph. But it's really more important for you to look at the mean blood pressure. So we draw a line right through the middle representing that mean pressure. When I give a drug, if that causes the blood pressure to increase, I would suggest that you first think about the change in blood pressure being caused by a change in TPR. Remember, the blood vessels have a greater influence on your blood pressure than the heart does. So if the blood pressure goes up, think blood vessels, think vasoconstriction. In fact, think about activating alpha-1 receptors. Many times, the unknown drugs in this type of problem are actually agonists. So think about agonists first. So an alpha-1 agonist would increase the blood pressure. On the other hand, if mean blood pressure goes down, think about a vasodilating effect, and that can be caused by stimulating beta-2 receptors. When you solve this type of problem, and you try to solve it in just over a minute, you have to have some very specific strategies in order to get through these efficiently. The blood pressure changes, think alpha-1 or beta-2. When you look at heart rate, on this type of diagram, heart rate is shown by measuring from one peak to the next peak. You could also measure from a trough to another trough, but that represents one heartbeat. If the peaks, for example, were to get closer together, that would represent an increase in the heart rate, so that is tachycardia. What receptor would you stimulate to cause tachycardia? Well, that would be beta-1. On the other hand, if the peaks get farther apart, representing a decrease in the heart rate, bradycardia would be caused by activating muscarinic M2 receptors. These 4 receptors are critical for you to understand as you analyze this type of problem. So let's look at one example. We're asked in this figure to identify drug X. Who is drug X? Now, to the left of this figure, prior to giving drug X, that's going to be our control. There's our normal blood pressure and our normal heart rate. Then we give drug X. Notice that immediately the blood pressure goes down. Always look at the blood pressure first. The blood pressure goes down. You should respond very quickly to this. What receptor was most likely activated to cause a decrease in blood pressure? Beta-2, that's correct. Notice also, especially to the farther right of this diagram, the heart rate has increased. The lines are getting closer together, indicating tachycardia. So if drug X was an agonist, what receptor did it stimulate to increase the heart rate? That would be beta-1. Our initial analysis of drug X says that it's a beta-1, beta-2 agonist. You might be thinking of other options right now, but let's go with this. Once again, this would be the simplest explanation if drug X was an agonist. Beta-1, beta-2 agonist. One of the keys to solving this type of problem, however, is that heart rate effect of drug X caused by a direct action of this drug on beta-1 receptors, or is it that the reason why the heart rate is increased is because of the drop in blood pressure leading to a reflex tachycardia? Heart rate is always tricky. It can be direct or it can be a reflex when it changes. I can't really look at this picture and tell immediately if this is a direct effect or a reflex effect. What would be helpful, and what is more likely on step 1, is that they would give you a second experiment. And the second experiment would be a pre-treatment, perhaps with a ganglion blocker. If I give a ganglion blocker and then follow up by giving drug X, and I get exactly the same graph. In other words, if the ganglion blocker has no effect, what does that tell me? It tells me that drug X works directly on the heart to cause tachycardia. In fact, I can conclude drug X is beta 1, beta 2. But what if the ganglion blocker prevented the tachycardia? If I pre-treated with a ganglion blocker and then gave drug X, my blood pressure still went down, but the heart rate stayed normal. What would that indicate? That would indicate that the effect on the heart was a reflex and that drug X only worked on beta 2 receptors. And the beta 2 effect of vasodilation, dropping the blood pressure, is what caused a reflex tachycardia. That's how you would solve these types of problems. This is just a preview because we have several others that we're going to look at for practice. Next, we want to look at pupil size and accommodation mechanisms. First, let's start with the parasympathetic effect on pupil diameter. The parasympathetic effect is mediated by activating muscarinic receptors. M3 receptors are found on the sphincter muscle of the eye. When I stimulate those M3s, I contract the sphincter muscle, and that causes miosis. So that is your parasympathetic effect on pupil diameter. The bottom of the diagram shows you the effect of sympathetic activation on the eye. Sympathetics innervate the radial muscle, which has alpha-1 receptors. When I stimulate alpha-1s, I'm going to contract the radial muscle. But remember, this muscle is different. When I contract the radial muscle, that leads to pupil dilation. The sympathetic effect on the eye, mydriasis through alpha-1s. If you look right in the center of this diagram, however, what you see is the effect on accommodation. Notice, accommodation has nothing to do with pupil size. Rather, it involves the shape of the lens. And importantly, accommodation is purely parasympathetic. That's because accommodation is mediated by muscarinic receptors found in the ciliary muscle. Make a note here that sympathetics have no effect on accommodation. If you put this together, if I activate muscarinic receptors, pupil diameter, you're going to constrict, miosis. But then you're also going to get accommodation for near vision. But what if I block muscarinic receptors? I get the opposite. I get mydriasis and accommodation to far vision leading to cycloplegia. Muscarinic blockers will paralyze accommodation, and that's an important property to remember. Now, contrast a muscarinic antagonist with an alpha-1 agonist. They're going to have in common that they both dilate the pupil, but only the muscarinic blocker will affect accommodation. I get no cycloplegia with an alpha-1 agonist. So you have to imagine, if you have a patient that's undergoing a dilated eye exam, and they're given two separate drugs, both drugs are going to dilate the pupil. One of them paralyzes accommodation. Could you identify those two types of drugs? The one that dilated the pupil but had no effect on accommodation was an alpha-1 agonist, perhaps a drug like phenylephrine. The other dilated the pupil and paralyzed accommodation. That would be a muscarinic antagonist, some drug in the atropine family, perhaps a drug like tropicamide, which has a shorter action in the eye.